Spencer Gainey. My talk is on values-based practice in the age of EHR, the electronic health record. The values-based practice, this program is supposedly for CME credit through the SCMA. I have no conflicts of interest. However, at this time, I'm an employed physician of Spartanburg Regional, member of both the SCMA, the AAFP, and the SCAFP. So weigh that with a grain of salt against what I say. Per CME guidelines, after this presentation, you should be able to define values-based practice, recognize the ethical considerations of value-based practice, which will be abbreviated as VBP from here on out, and identify barriers to values-based practice, especially within the confines of an electronic health record, which we will all soon be using, if not already. What is values-based practice? It's a framework for medical decision-making. It is both a response to and an adjunct of evidence-based medicine. As such, it is called a twin sister of evidence-based medicine. It is the creation of Dr. Bill Fulford, who received his training at Oxford University and is on faculty at the Warwick School of Medicine in the United Kingdom, or as far as my interpretation of how they list things on their website and in his article. And the article that he wrote, as you can see at the bottom, from which pretty much all of this comes, is the 10 Principles of Values-Based Medicine from the Philosophy of Psychiatry. The values-based practice is a process to improve health outcomes. That's the way it was intended. And as such, Dr. Fulford created, I guess you could say, and elaborated on what he calls the 10 principles of values-based practice. This was initially done in the setting of psychiatry and trying to reconcile the different values of the psychiatric patients as well as the psychiatric practitioners, both the physicians and I guess their extenders or whatever the equivalent is in the United Kingdom. Again, I'm not very familiar with their method of delivering medicine. But the 10 principles, the first principle, which is the 2 feet principle, is based on values and facts. Values being the, of course, values-based practice, and then the facts, which is the evidence basis of medicine, to which Dr. Eppright will be speaking with us about shortly. The second principle is the squeaky wheel, the fact that values are only addressed in times of conflict. And third, science-driven, that as the science of medicine is further elaborated, there will be increased choices, both on treatment versus non-treatment, what types of treatment are available, what the roles and the risks of treatment versus non-treatment are. And as the increase in choices in medicine and medicine delivery continues, so will the increased role of values continue because there will be an increased number of decisions, and so the values behind those decisions are increasingly important. Those first 3 are the philosophy of the values-based practice. Next, patient perspective. The patient's perspective, the patient's values, is the first call for information in a values-based practice approach. What the patient believes, thinks, feels, all of that information is going to be the first set of information we need to look at in addressing how we practice medicine from this perspective. Second is the multi perspective, which is everything else, the physicians' input, the input of, I guess, payers of medicine and the families of the patient, even, I guess, governmental concerns and values, and that the underlying principle here is that all those, there needs to be a balance of those values, that everyone's value is equally valid. There's no, even though the patient's is the first to be called and used into, the first kind of information to be called and used in determining the values, they all are valid. There's no one right answer. And these two principles are the policy of values-based practice. Values blindness, this is about using language in context. I don't know how to explain this one, but it's basically the in the context of the relationship between a patient and with that decision to be made at that time, that relationship at that time, that the language is going to kind of inform what the values that are expressed and understood. And the next one, which is similar, values myopia, that there are increasing resources becoming available to learn to understand different values that other people have. Basically, my understanding, what I'm trying to elaborate for you all as well, it's not just a plain vanilla writing on the piece of paper, in this situation you make this decision. And I'm sure most everybody here in practice understands that and does that. The goal with this, though, is to help us to be aware of making this an active process, and I'll get into that a little bit more, going beyond what we're thinking and doing now, possibly. Next is the space of values, ethical reasoning to understand the values using our medical ethics, our bioethics approach to understand what the values are and why those are important in the decision process. And how it's done is the principal use of our communication skills to arrive at elaborating and elucidating the values. These are principles 6 through 9 are called the practice of values-based practice. Those are kind of the rubber meets the road. And finally, who decides, which is probably what everyone here wants to know. It's the relationship between the doctor and the patient. This is the alliance, and this principle is referred to as the alliance between a patient and a physician. That alliance is what is going to inform the decision ultimately. It's not up to outside ethicists or lawmakers. Ultimately, the decision rests with the patient and the physician. It's in their hands. The decisions, the communication, everything that goes on in the practice of medicine. So, why should we consider values-based practice? As you can see, just as evidence-based medicine is a process to adapt to the ever-increasing number and complexity of medical facts, values-based practice is made to accommodate the ever-expanding and potentially conflicting values in medical decisions. The world is getting increasingly smaller. We are running into each other and into others who have different and disparate values than we do, and to ethically provide medical care, we need to be aware of those values and how do we incorporate values of others in how we deliver medicine, and then in how medicine is delivered as a whole. The problem of conflicting values has always existed. was not always necessarily addressed in an ethical manner. Usually this is referred to with tradition and hierarchy, the deference to the physician as the decision maker, the hierarchy that, you know, it's not the medical student, it's not the resident, it's not the attending, whatever. That there's a hierarchy in the decision-making process, and this is an attempt to get away from that, to, I don't know if you want to say empower, but to at least elucidate the values that underlie that relationship between patient and physician, to ultimately get at the underlying values and have a decision made accordingly. Values-based practice is a dynamic process because values are based on our identity, which is a changing from day to day. Dr. Roberts would be much better at explaining this with his psychiatry training and expertise, but it changes throughout our lifetime. Values-based practice, like evidence-based medicine, involves both theory and skills. I put the poems versus DOEs, patient-oriented evidence that matters versus disease-oriented evidence. What research shows us that the evidence that we should use to treat patients for better health outcomes versus what the drug companies try to sell us as how their drug impacts the disease process. That's one of the skills that you learn in evidence-based medicine and values-based practice. The skills of communication, I guess you would say openness. Those are skills that have to be honed and practiced on a daily basis, just like you would with evidence-based medicine. Values-based practice can help achieve ethical care in medicine, specifically the principles of autonomy and to a degree justice, the autonomy, the self-governing, the self-law, self-rule of a patient. If they are not, if our, as physicians, our values are the only ones informing the medical care, then there's not truly autonomy in medical practice. So going from defining values-based practice, which was a new concept, at least as far as a defined concept for me, to the barriers. The first two, ignorance and apathy, as Yogi Berra said, I don't know, I don't care. Ignorance, from the Socratic, we don't know what we don't know. If we don't ask the question, we won't know. We need to ask patients, what are their values, what informs what informs them when they are seeking medical care. And then there's the assumption of shared values. Just because I'm white Southern male does not mean that someone else who's a white Southern male agrees with me. And it definitely shouldn't mean that anybody else agrees with me. And what I'm assuming is my values that I bring into a relationship between a patient and a physician. Apathy, a lot of this, I don't really care what other people's values are, because this whole values-based thing is touchy-feely. Isn't this just for psychiatrists? What role does this have in objective scientific medicine? That can be a barrier to delivering values-based care. Cost. This is probably one of the biggest ones. It's time-consuming. Letting patients have their time to speak doubles the time of the visit. And who's going to pay for that? The power differential and the concepts of transference and countertransference that we probably briefly studied when in medical school, but hopefully still have an idea about. And this is very much still in play, that being the physician, we hold the power in the relationship. I think with I guess in Dr. Limehouse's talk about the paying the popular physicians more, that power differential may soon sway as we start to kowtow to our patients' demands in order to actually get paid. But still, there is always a power differential. The pendulum's never just in the middle. And the final one, subjective, and I think this plays kind of into the ignorance and apathy side of it. Values are difficult to define, and they can change, and we don't like that. We want nice, hard scientific facts that we can repeat over and over, do the same thing over and over. Like with the order sets on computerized order entry, we want to be able to click that one button and move on. We don't want to have to keep chasing our tail on the same question over and over, especially not with the same patient. So these are all barriers to values-based practice. In the setting of an electronic health record, which can have its own barriers to care in general, not just values-based practice care. Values-based practice, using these principles, it may be more of a tool for communication. And communication, ultimately, as physicians, we are looking for data, discrete information points to help us arrive at decisions, and the best way to get that is through communication. It's hard for us to make decisions, sound decisions, if we don't get the data we need, and values are part of that data. So using the skills, using the different principles here can help improve communication, help us get better data that, although it may not be the objective evidence-based data, it's equally valid because it affects how we deliver our care and how patients receive the care. And the electronic health record, how it plays into that is a very good question. The one problem with the electronic health record is it's right now seems to be a very clunky tool. Recording information in electronic health record, it depends on which product you have, but you can either have free entry where you can type information in, or preset information that you can click on. How do you take a patient's values? How do you take your own values and record that into an electronic health record? Don't really do that in the old handwritten record either, but especially with trying to make health information more portable and accessible, how do we document what the values were that came into the decisions that were made on certain treatments or non-treatments, on the care that was provided for a patient, especially if that information is going to be taken somewhere else. If we're seeing a patient who is, in the case of Dr. Limehouse, in an emergency room setting, is from out of town, they don't have a doctor there, they come in to be treated, how can he document what his values, what the patient's values were, and that carries forward with the patient elsewhere? That's a good question. I think we are kind of at the stick and stone stage of the electronic health records, much in the kind of caveman analogy. We haven't sharpened our weapons. We haven't made our tools as sleek and as user-friendly as they can be, and hopefully with further iterations that will improve. But with all the mandates, all the pressures, it's increasingly difficult to do that. But anyway, so using values-based practice and in an electronic health record, we've got to find some way to document that, got to find some way to use that. Values-based practice emphasizes the importance of the relationship between the physician and patient. So I think putting that into the record, the way we put that in can often reflect the values we have in how we see the patient. And again, finding a way to get that into an electronic health record that the patient can carry with them, that can hopefully show a physician in Fort Lauderdale what this patient wants when they, or sees as important when they present for care on their vacation. Values-based practice leads to the patient owning the decisions made in the process, again, to autonomy, and being able to document that in an EHR. You can approach it from a liability standpoint. You know, hey, this is what the patient wanted, and all the benefits and consequences thereof lies with them in that decision and in the outcomes of this process. But from a broader approach, to truly ethically incorporate care, we do want to do more than just pay lip service to autonomy and more than just ask them what they want. We want to find out who they are and how that influences, how that speaks to who they are and what they want. Again, with the electronic health record and the opening of health information and the patient owning this, again, want to get back to that whole idea of meaningful use and meaningful use of the health record being available for the patient to access, and not necessarily access it to change, but access to see what is in there, and also access to other physicians who may be treating this patient in the future. We've got to find some way to have that in there and to use that information. Just because it's in there doesn't mean we necessarily will use it. Just like blood pressure and monitoring a patient's weight, blood pressure, we need to be able to monitor and use their values when we deliver health care to them. So we're getting now to the question to make this truly a continuing education type activity. And this, you can tell by reading this what my value as a physician in talking to a patient, and that was pointed out when I first gave this talk to our, at our retreat to the committee. But which of these statements, in my opinion, not necessarily your opinion, best reflects values-based practice? Letter A is lowering hemoglobin A1C levels from 8 to 7 reduces stroke risk by 10 to 20%, so let's intensify your insulin regimen. Letter B, changing from warfarin to dabigatran reduces stroke risk 35%. You want to change your medicines. C, atorvastatin and simvastatin are equally effective in improving lipid profiles. Let's start simvastatin because it is cheaper. Oops, sorry. And D, medication and therapy are equally effective in treating major depressive disorder. Our office psychologist can see you right now. So, based on what I've said and what you see as who I am, which of these statements do you think most accurately reflects values-based practice, and at least the way I've presented it to you? Anyone for letter A? Anyone for letter B? A few hands. Letter C, and letter D. All right, the correct answer, in my opinion, is B, because we're trying to get at what the patient would want, letting them make the decision. Of course, as Dr. Apt pointed out to me, in some cultures that would be me assuming that that's what the patient wants. In some cultures, patients want the doctor to make the decision. So, again, this varies. It's a variable process. It's a very dynamic and subjective target to achieve. So, I would say we can say every answer is right, and we're not keeping score. This is just for purposes of education. So, in summary, I like quotes, historical quotes especially. Learn avidly, question repeatedly what you have learned, analyze it carefully, then put what you have learned into practice intelligently, by Edward Crocker. And then one of my favorites from Blaise Pascal, Do not draw the conclusion from your apprentice studies that you have nothing left to learn, but rather you have infinitely more to learn.